Welcome back to The Explainer. So today, we're cracking open a sort of medical storybook. It's a tale of two very different but equally devastating fibrosing lung conditions, cystic fibrosis and idiopathic pulmonary fibrosis. If you're prepping for the boards or just really want to perfectly categorize these two diseases in your head, you are literally in the perfect spot. We're going to build the ultimate exam preparation breakdown today.
Okay, let's just dive right into the roadmap. We're going to hit origins and pathogenesis, clinical features and mnemonics, diagnosis and simple imaging, contrasting management approaches, and wrap it all up with the ultimate exam comparison chart.
All right, Part 1, Origins and Pathogenesis.
But before we get into the heavy science, it really helps to ground this stuff in the real world. You probably recognize this movie poster, right? 5 Feet Apart. It really brought cystic fibrosis, or CF, into pop culture, and it highlighted just how severe the realities of this fatal genetic disease actually are. It's just a really powerful reminder of the human element behind all the pathology we're about to study.
So right off the bat, there's a massive, stark contrast in where these two diseases actually come from. On one side, we've got CF. This has a completely understood genetic inheritance. Actually, it's the most common fatal genetic disease in Caucasians. But on the flip side, we have idiopathic pulmonary fibrosis, or IPF. And while idiopathic is just a fancy medical way of saying we have absolutely no idea what causes it. It's the most common idiopathic interstitial pneumonia out there, but its actual triggers, complete mystery.
Now, CF is essentially caused by a broken cellular gatekeeper. The CFTR gene, which sits right there on chromosome 7, usually codes for a chloride channel that manages salt and water movement. But when it mutates, the whole system goes haywire. You end up with increased sodium chloride in your sweat and this massive resorption of sodium and water from the respiratory lining. And the result? Your airways literally dry out.
Moving on to Part 2. Clinical features and mnemonics.
Because of that complete lack of water we were just talking about, the mucus in a CF patient becomes unbelievably thick and sticky. I mean, this stuff acts like a physical plug. It clogs up the airways, traps bacteria, and totally sets the stage for chronic, recurrent pneumonias. Initially, you'll see infections from Staph aureus, but later down the line, Pseudomonas becomes the major culprit.
To completely lock this down for test day, just remember this incredibly simple mnemonic. CFCF. C is for chloride defect, which we test via sweat. F is for fat malabsorption, because that exact same thick mucus blocks up the pancreatic and bile ducts. The next C, chronic pneumonias. And the last F is familial, to remind us of those genetic roots on chromosome 7. Oh, and keep in mind, men with CF are typically infertile because they're missing the vas deferens, and roughly a quarter of adults develop diabetes from all that pancreatic damage.
Now let's contrast that with our IPF mnemonic. I stands for inspiratory crackles, specifically those bibasal fine crepitations you're gonna hear through a stethoscope. P is for progressive dyspnea, which comes with a super dry, non-productive cough as the lungs slowly turn into stiff scar tissue. And F, 50 to 70 years old. Guys, this is absolutely crucial. Unlike CF, which you diagnose in young folks, IPF is largely a disease of older adults. You're almost never going to see IPF in someone under the age of 50.
Which brings us to Part 3, Diagnoses and Simple Imaging.
So the crucial point here is understanding how we definitively prove these diseases exist. For cystic fibrosis, the diagnosis is biochemical and genetic. We're looking for sweat sodium and chloride levels over 60 millimoles per liter, and we follow that up with DNA testing. But IPF? That diagnosis relies heavily on imaging and mechanics. We use high-resolution CT scans, HRCTs, and pulmonary function tests, which will predictably show a restrictive pattern because, well, the lungs literally just can't expand.
When you look at an IPF chest scan, it usually marches through 3 distinct steps, slowly destroying the lung architecture. Stage 1 is this ground glass appearance. Then it evolves in Stage 2 into irregular reticulonodular shadowing, mostly down in the lower lobes. And finally, by Stage 3, the relentless scarring turns the tissue into what we call honeycomb lung.
Now, to make that ground glass term really stick, just imagine looking out a foggy window on a cold morning. You know something is out there, but the sharp details are completely obscured by this hazy, grayish veil. That is exactly what early fluid and inflammation look like on a scan, right before that severe, permanent scarring of IPF sets in.
And this brilliantly illustrates what happens in those later stages. Those advanced honeycomb cysts can get up to a centimeter across. It literally looks just like a beehive. Plus, because all that surrounding fibrosis is constantly pulling and tugging at the tissue, the normally crisp edges of the heart get all fuzzy and frayed. We actually call this the shaggy heart border. It's a classic, dead giveaway visual marker for severe pulmonary fibrosis.
All right, part 4, contrasting management approaches.
The overarching treatment philosophies here are literally night and day. Treating CF is basically a plumbing issue. Our main goal is to clear the blockages from the lungs and replace the digestive enzymes and vitamins the body is missing. But treating IPF, that's more like trying to soften a sponge that is slowly turning into stone. The philosophy there is mostly supportive care, focused entirely on just trying to slow down the inevitable scarring.
So for cystic fibrosis, our arsenal is highly targeted. We give pancreatic enzymes and fat-soluble vitamins to fix the digestion. We use chest physiotherapy and bronchodilators to physically knock that sticky mucus loose. But one absolutely fascinating treatment is inhaled rDNase. Get this, when white blood cells die fighting lung infections, they leave their DNA behind, which actually makes the mucus even thicker. So rDNase is an inhaled enzyme that literally chops up that leftover DNA, making the mucus way easier to cough out. You add in some heavy-duty antibiotics and vaccines, and you've got a really solid management plan.
IPF care, unfortunately, is a whole lot tougher. We use oxygen for the shortness of breath, and sometimes even opiates for severe dyspnea, maybe alongside steroids or immunosuppressants. Medically speaking, we really rely on specific antifibrotic agents, like pirfenidone and tyrosine kinase inhibitors, like nintedanib, just to buy time. But at the end of the day, none of these actually cure the disease. For IPF, the only definitive therapy is a full-blown lung transplant.
And finally, Part 5, the ultimate exam comparison chart. Seriously, if you take a screenshot of anything from this explainer today, make it this chart right here. This is your ultimate cheat sheet for test day. Just look at the breakdown. Demographics, CF is young and genetic. IPF is older, 50 to 70. Pathology, CF is a broken CFTR gene causing thick mucus, while IPF is progressive scarring from an unknown cause. Key signs, CF gives you fat malabsorption and recurrent pneumonias, whereas IPF presents with progressive dyspnea and bibasal crackles. For diagnosis, you're relying on the sweat test for CF and the HRCT for IPF. Imaging shows airway destruction in CF, but ground glass leading to honeycombing and a shaggy heart in IPF. And management, CF is all about enzymes, physio, and rDNase, while IPF requires oxygen, antifibrotics, and eventually a transplant.
And that brings us to a final, kind of provocative thought. Medical science is moving incredibly fast. With the rise of these revolutionary gene therapies actually correcting the CFTR defects in cystic fibrosis patients, we really have to ask, will lung transplantation eventually become almost exclusively a treatment for mysterious, idiopathic conditions like IPF? It's a fascinating question about where pulmonary medicine is heading, and I really hope it leaves you curious to dig a little deeper. Thanks for hanging out with me for this explainer, and I'll see you next time.